This is Metabolic Mastery, a KORR Medical Technologies podcast dedicated to advancing knowledge and practice in metabolic testing. Welcome to Metabolic Mastery, brought to you by KORR Medical Technologies. I'm Dr. Marc Humbert, and this is my co-host, Dr. Cameron Garber. And today we're going to be talking about Submax and maximal VO2 testing. We get a lot of questions on this.
Yeah.
Like, what should that look like? How am I determining max? Like, how do I design my test? And as a good precursor to this episode, it might be a good idea to go back and watch. I think it's episode 7 and 8. And so that's really the big thing. But like, what do we want the test to look like? What are some of the considerations that we have?
And how do we know if we've reached a true VO2 max or not?
Yeah. And so really what we want to start with is, what's our goal? What are we intending to measure?
Yes.
And that is going to govern the design of our protocol, why we would use, different protocols, cycling versus treadmill versus something else, whether we're going to do max or a submax test. The best test is not necessarily the quote unquote hardest test. It's the best test is the one that's designed to measure what you're looking to measure. So there's certain types of testing where we're not going to max,
right,
because we want to zoom in on a certain thing. And so that would be one example of a type of submax test.
Yeah, like a fat max test, where it's very submaximal. We're just trying to see where is their highest rate of fat oxidation. And so we stop at that fat max point, or slightly beyond, but we don't need to go to max. And so this is one of the reasons why I don't call it VO2 max testing at Body Smart in our clinic. We call it exercise metabolic testing. So we have a resting metabolic test and an exercise metabolic test. And the reason why we call it that is so that we can get away from the idea that everything is just about the VO2 max, although an important number and very helpful with certain things, and looking at all-cause mortality and risk ratios and all those things can be helpful. But it's not the end-all be-all number. And that's one of the things I love about the cardio coach is it's not just designed for VO2 max only. It's designed for really doing physiological testing, like we've talked about with Daniel Crumbach, where we can look at lung values, where we can look at metabolic values, where we can look at energy systems and how those are working. And so the cardio coach really does allow us to do a broad range of tests so we can test what we intend to measure. And so I love that about it. It's one of the reasons why I use it in the clinic. And so calling that exercise metabolic testing allows us to do the type of test that we may feel like that patient needs to be able to assess what we're looking for them.
Yeah. And so when we look at the traditional VO2 max tests, there's a ton of different protocols that are validated in the research. But often what those are selecting for is pure VO2 max.
Right.
We're not necessarily caring about other numbers. It's just, how can I get the highest VO2 max possible?
Those are research protocols for research studies or for doing like stress tests or things that have been validated to be good for a stress test because it gets you to maximal exertion rapidly.
Yeah.
But not necessarily always great at doing submaximal or doing tests where we look more at substrate utilization.
Yeah. And so many of those max testing protocols end up blowing through lower heart rate zones. And so we
just
don't
very rapidly.
Rapidly. It's just a very quick ramp, which again works very well for the intended purpose, right? If it's for research, if it's for those stress tests, it's doing what it's designed to do. And so it's completely appropriate.
Yep.
If there are things that we want to look at more broadly than that, then we're going to want to change the test design. But in general, when we're running a good VO2 max test, we want to make sure it's a graded protocol. And so you want smooth workload increases. And so really any piece of equipment that allows for a progressive increase in resistance across the course of the test can be utilized. And so you want something so like treadmill and cycle ergometer are the most commonly used.
Yep.
And so with treadmill, it's speed and incline. With a cycle ergometer, it's wattage, and RPMs are the readouts that it gives. And you can have other things like ellipticals or erg rowers or different things like that, like so many different types of equipment.
Right. I've even seen step tests done where you use a metronome and you start on a stair and you just increase by 10 beats per minute every minute or 3 minutes or however you want to do it. If you did 3 minutes, you'd want to do larger increases every stage. But yeah, you can do step tests where they just step up and down.
Yeah. But having something that is easily quantifiable, right? It's
Yep.
like we're going to, even with a step test, like we're going to increase the metronome by this much each minute.
Right.
I know how much I increased it by.
That's the in the graded exercise test, that's the grading, is we can do it at different grades of difficulty as we go.
Yeah. And so why do I bring that up? Because there are certain types of exercise equipment that increase resistance, but not in an easily quantifiable way.
Right.
And that means designing the protocol for those can be very difficult and tricky.
Right. Like the Schwinn Airdyne. Great bike. Love it. Love what it can do, with both arms and legs and the big fan. It cools you as you go. Like, great. But it is harder to design a protocol for that because it doesn't have a readout necessarily. An assault bike is another one that's common, that it's hard because you have like dial resistance on the Schwinn Airdyne or the assault bike or even a Peloton, where the resistance is a dial. And so it's harder to dial in wattage or things like that. And some of those bikes don't give you a readout on your RPMs and stuff. So doing a graded exercise test is hard because it's hard to kind of feather the grading.
But then also, like, is this appropriate equipment for the person in front of me?
Another common one we get questions about all the time is the curved treadmills.
Oh,
that are
yeah, thank you.
self-propelled
Mhm.
curved treadmills. We get that a lot. And those, it's not that you can't do a test, but they're harder to do a test because it's hard to grade the exertion. And then, but you can do, one of the things with the cardio coach that's awesome is you can do it in that open-ended long form mode and just track their workout. You say, you do your regular workout on there and we're just going to track what happens. And so that's a different way of just seeing, are they doing what they think they're doing from a metabolic standpoint? When they do a workout on there, are they really in zone 2 or are they higher, lower, things like that? We can test that and see. And so it's not that you can't use those, you would just have to do it differently.
Yeah. But just with different equipment, there's going to be different metabolic demands, right? Depending on, like with that treadmill, an example, like what's the strike pattern? How does the self-propelling work? How does that compare to overground running? Like those are considerations to have. And so, for example, like VO2 testing on treadmill is typically 5 to 10% higher than what you see on ergometer. There's different mechanics and there's different metabolic demand. The bike, especially if you're not clicked in, is very largely quads.
Yeah.
Versus running, you're going to get more of a full body use, and so you're using more muscle mass. Therefore, your oxygen utilization and requirement is going to be higher. And so considerations like that. And so like the values that you get on a cycle max test are specific to that mode of exercise and aren't directly translatable to the values you get on a treadmill.
Right. Your VO2 max will be different. Your heart rate zones will be wildly different. Your calorie burn numbers will be very different per each heart rate range.
And so as you're setting up a max test, that's the question that you want to ask. What is the mode of exercise that this person is currently doing or is planning on doing for their exercise? And that's what you're going to want to choose for max testing, because that's going to be most directly applicable to what they're going to be doing in real life, right? And so if they're a cyclist, cycle. If they're a hiker, then do more of an incline protocol versus speed. If they're a runner, you're going to want to do more of a speed heavy protocol. And
if they're into backpacking or rucking, you can even have them bring their backpack.
Yeah, you've done
a rucksack. Yeah, I've done that
way.
Yep. So that you're challenging the same muscles that will be challenged, because so walking is done mostly in your calf muscles. So 60% of what bears your load and propels you forward during walking is your calf muscles. So your gastroc soleus complex. So when you add increasing loads, some of that shifts then somewhat to more quads, glutes, and hams, which are still always active, but they take on a greater role when we have an increase in like load, especially kind of back behind us with a rucksack. And so, just considerations to make, that we're changing the way those muscles are being loaded and how they're fueling fueling with oxygen and utilizing fuel. And so, again, test what you intend to measure. If that's their primary mode of exercise, test their primary mode of exercise if you can.
Yeah. Another consideration for some people is safety. If there are individuals that you're concerned that can they stay upright and safe on a treadmill, like that's where you might use the cycle protocol, and that's good enough. And
Yeah, you can still track changes so it may not be the absolute best for getting their heart rate zones or other things, but we can track changes over time, especially as they're starting out a fitness journey. If you feel like that's safer, that can be a great way to track progress. And it may be that they're at low enough intensity exercise that we kind of know that they're just going to be walking anyway, and that's okay.
Yeah. There's no one best mode. It's what is going to work best for, safety considerations and for the general use of that client.
Yep.
So important things to consider. Next is test length.
Mm-hmm.
On average, you want them to be like for when we're like max testing, 8 to 15-ish minutes.
Yeah.
Some will go a little shorter, some a little bit longer. If you build a warm up into the protocol, that
can be a little bit longer.
That can do it a little bit longer. But what you want to be careful of is if they go too short, right? If it's too intense, they might just develop peripheral fatigue in the working muscles before a true VO2 max is reached, before they hit some of those thresholds.
Yeah.
And if it's too long, sometimes people just get really bored.
Yeah. Well, and they wear out their legs before their lungs.
Legs before lungs.
Yeah. We see that in cycle tests a lot, especially where, because it is so quad dominant, if they're not a cyclist, we're going to see their legs burn out before their lungs do. So they stop because of the pain of pushing their quad so much, versus like that really was the maximal amount of oxygen I could consume.
Yeah, no, such a good point. And so kind of trying to find that Goldilocks zone.
Mm-hmm.
And so what that means is that, and this is, go back and listen to those previous episodes, but this is also like picking a protocol that is going to be consistent with the client's level of fitness. If, again, they're regularly running and you do a bike one and you do a bike one that would be better suited to people that are like regular cyclists, then again, they might burn out well below that. So we tested an individual several weeks ago, and like CrossFit athlete, like quite a bit of muscle mass, and just like overall very fit. But we had to use a bike just because of equipment limitations at the time. And like, because of her size and because she wasn't doing quad dominant things, like she tapped out with muscle fatigue way before we would have expected her to like hit the cardiovascular limits. And then just based on what she'd told us about other exercise and her tolerance and her ability to push, like it was very clear that test was just not like going to be the best to elicit a good VO2 max for her.
Right. Well, for what she was training for.
And what she was training for, especially.
Yeah. We tested it. This was at the Health and Fitness Association conference, which we were doing bike tests there, and we tested another guy who is an endurance runner, like great runner, very fit, great runner, and his VO2 max was significantly lower than what we would have thought. Still in the superior category and everything, still was good, but it was kind of like near the border. But it was mostly just because it's a quad thing. Yeah, it was just his quads, and he was used to using his whole butt.
Well, the guy who actually was a cyclist that got on there just
crushed it,
like blew things out of the water. It was awesome.
And so you got to be careful in choosing what your max test protocol looks like for a cycle test. If you're going up by 10-watt increments on somebody that's an experienced cyclist, it's going to drag the test way out. But if you're going with somebody that's not an experienced cyclist and you're going in 30-watt increments, they're gonna be within just a few minutes at 300 watts and pretty fatigued. And so it's just seeing kind of where they're at and judging kind of test length plus what their capacity is. And so if they already know their FTP, their functional threshold power, if they're a cyclist, that can be really helpful at saying, okay, if I want the test to be 10 to 12, maybe 15, depending on how fit they are, minutes long, but kind of in that 8 to 12 minute range is ideal. You can kind of do the math and say, if I'm doing 25-watt increments, it's 100 watts per every 4 minutes, and yada, 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 and kind of figure out where you want them to be based on what their functional threshold power is.
Yeah.
If they know that.
For sure. Bottom line, like just what is going to get the client to fatigue within about 8 to 12 minutes, 8 to 15 minutes.
Yeah.
And then what we want to see is something that also gives us that nice linear progression in heart rate. So we'll see some protocols that will just jump, like the jumps between each stage are so big that it's like, oh, we got a 10 beat per minute jump here really quickly.
Yeah.
And so just if we can get something that gives us that nice linear response, that just makes the interpretation portion of the test a lot easier, and gives us more actionable data.
Yep.
Okay, so let's jump into submax testing. So as we talked about, like there's multiple types of submax testing. And so like there are different considerations, but like when most people think of submax testing, they're typically thinking of people who are, have lower conditioning, or maybe there's a standard that someone needs to reach and they only need a submax test, right? So they don't feel the need to push someone to max because they just need a certain number.
Yeah, we'll get this with police and firefighters or things like that, military, where they just need to know that they can pass this certain portion of the test. And so once they kind of get there, often they'll be like, okay, I passed, I'm done.
Yeah.
And that's okay. Yeah, as long as we see where they're at. Often they're competitive too and want to see what their capacity is, which is also great. But designing a submax test, especially for those just starting out, we kind of teased that on the last episode. For people who are just starting out with a fitness journey, or people who are battling obesity, that doing a submax test is often a good way to start, because we're not going to overtax them for not only their heart and lungs that may not be ready for it. So we don't want to, create a situation where we're causing cardiac events, obviously. But also just because their tendons, ligaments, bones, muscles are not attenuated to some of these loads, it's okay to do a submaximal test and then make that goal number one, of saying, now next time we want to improve your fitness enough that you can get closer to your true max. One of the cool things with the cardio coach is it does ask the question at the end of this test, was this a max test? And so even if you run a test that you feel like was a submaximal test, you can click that button and it will give you an extrapolated VO2 max. So it uses the data so far to say, based on this, extending out to what your likely max heart rate is, this would be your extrapolated VO2 max. And so really helpful in being able to see where somebody probably is if we were to push them, but without having to push them in a situation where we feel like, maybe this isn't the safest time, if they haven't exercised in 30 years, to push them to a true max. And so it gives us a great goal of saying, let's build up to that. And so we're going to do a submaximal test now. And as we go on your fitness journey, that'll be one of our goals, is to get to where you can sustain those higher intensities to be able to do a max test.
Absolutely. One thing that I want to add specifically about the cardio coach is the limits of that extrapolation.
Yeah.
So it will only extrapolate up to 20 beats per minute past the peak heart rate.
Right.
Just because if we get too far beyond that, then it just becomes less and less reliable.
It becomes more of a stab in the dark.
Yep.
Yeah.
It's kind of like, you can think of it like as a funnel opening up. Like the further away that we get from the last data point, the more uncertainty there is.
Right.
And so if we go too far, you add too much uncertainty in there.
Right. And so that's an important point with that extrapolated max. We had a group of firefighters that was wanting to do a submax test and then use that to say, well, it extrapolate that they should be able to pass that test. And it's like, no, we don't want to, like on something like that where somebody's health and safety is on the line here, we don't want to use the extrapolated value to say, well, they could have passed the test.
Yeah.
Right. So we have to be careful and use that somewhat with a grain of salt of like, no, they need to be able to pass the test if this is other people's lives on the line, that you have enough fitness to be able to do that. So that extrapolated max is just more of a guideline than a clinical value.
Yeah. It becomes more useful the closer we are to our age predicted max. There's some considerations with age predicted max we'll talk about later. But like, let's say that your age predicted max is 180 and you get to 160. Like that will give a better extrapolation versus my max heart rate during the test was 120 and it only extrapolates up to 140, right? That probably doesn't give an idea of your true capacity in many cases.
Right.
But can still be a very useful thing and useful guideline. For kind of your traditional submax tests, it's often to like 85% of their age predicted heart rate max or 70% of their heart rate reserve. Just getting enough intensity that we get some of those thresholds. So often it's kind of considering what is the data that I need, and then stopping once I've gotten that data.
Yeah.
And so in many submax tests, I want to get aerobic threshold and I want to get anaerobic threshold. And once I've gotten that, I can
Then
stop.
we stop. Yeah.
Or in the case of a fat max test, like once I've gotten good data around that fat max point, then I can end the test. I don't have to continue. I don't have to increase intensity. And so like, what are the data points that are most important to me? And that's going to govern the length of time in the test and also the design of the protocol.
Yeah. And so honestly, my protocol is often the same when I run a submax test versus a max test. I just set a limit as to where we're going to stop, if that makes sense. But I run them through very much the same protocol usually. And I run all of my tests as what I call a symptom limited test, where I tell the patient before we get started, I say, we're going to have you go as long as you feel like you can safely go. So when you feel like you need to be done for whatever reason, then we're done. That way we stay kind of in a safety threshold where I always say my number one goal is that you stay upright through this whole process. And so that's kind of the idea. If for whatever reason they feel like they need to stop, then we can be done. And then that becomes a submax test. If they didn't reach their true max, we say, okay, this was a submaximal test, and we can use that extrapolation or look at their peak VO2 versus the extrapolation and say, okay, this is how much fitness we really need to gain first. It's just getting to where you can reach what your potential, your physiological potential is versus what you're kind of currently capable of doing because of your current level of conditioning.
Yeah.
Yeah.
Okay. So what qualifies something as a max test?
Ooh, great question.
There's several different things to consider, and it's not just one thing. I think sometimes people are like, oh, I hit this point and I'm good. It's
Right.
using multiple indicators to say like, oh, this was likely a max test, right? They hit several of these points.
Right.
And so having an idea of what those are can be helpful. So there's some back and forth in this in the literature, but traditionally the one of the big indicators was seeing a VO2 plateau or an increase of 150 milliliters per minute or less.
Mm-hmm.
And so like what that would amount to is either plateau or a significant leveling off. And so what we're saying is as workload is increasing, VO2 is plateauing. And so like we have reached a VO2 max.
Right. We've literally reached the maximal amount of oxygen uptake.
Yep.
And that's basically what V is, oxygen uptake. So the VO2 is oxygen consumption. So we've maximized our oxygen consumption.
Yep.
So hopefully that definition helps of what a VO2 max test really is. And so, yeah, that's kind of the purest definition. We often get a lot of kind of, if you reach 1.05, I've seen anywhere from 1.05 to 1.2 people saying that on the RER, so the respiratory exchange ratio, or the ratio of carbohydrate to oxygen.
Carbon dioxide.
Or carbon dioxide to oxygen. Tongue-tied this morning. Carbon dioxide to oxygen, that ratio of 1.05 to 1.2, that a lot of people say if they got there, then they were close enough to their VO2 max.
Yeah. So ACSM, I think, uses 1.1 as the criteria. 1.1. Some of the like Cooper Clinic and stuff have used that same one, but so 1.1.
Yeah.
But yeah, like
I've seen a range. So functionally, 1.05 is fine, but it's a little on the low side. 1.2, people are busting their guts to get there, and so I've seen a few people say that. But I think the 1.1 is better, just because it's more doable.
Yeah.
But often we don't fully see that plateau at necessarily at 1.1. Depends on the person and how well trained they are. For elite athletes, sometimes they're not fully plateaued until they hit closer to 1.2, and so that's why I've seen that in some things.
Yeah. Well, and I think it can be good to consider a range because it's not just one point. We're looking at multiple different factors and seeing what's happening. One point that I'll make that real quick is that in very fit individuals, AT and VO2 max can often be very close.
Mm-hmm.
And so people like wonder about that when they're doing a test. They're like, oh, they were right by each other. What's up with that? And it's just that like, with that person's style of training, they have improved their body's ability to clear metabolic byproducts that lead to fatigue. And so they can kind of get very high level doing that. And that's right around their VO2 max.
Right. Yeah. The anaerobic threshold is pretty close to where their VO2 max is.
Yeah.
And yeah, so that could signal maybe they need to do more VO2 max training, or their anaerobic threshold training is really high.
Yeah. Okay. So we've got that plateau. We've got RER of 1.05 to 1.2. RPE, your rating of perceived exertion, is typically going to be pretty high, like
10 out of 10.
10 out of 10,
Yeah.
right? 9 to 10 out of 10
Yeah.
on that. And then another indicator you can use is a percentage of their age predicted max. And so I'll look at like 95% of their age predicted max. Did they reach that? That can be another good indicator. Just the thing to be aware of there is if people are on beta blockers or things like that, then their heart rate is going to be capped.
Yeah.
Below what you'd expect for their
Right.
age.
Well, and some people just go way higher than their age too.
Yeah.
My wife, I've seen even fairly recently, like 205, which age predicted max would put her like 180.
Yeah.
And so, to see her in near 200, but some people just have that higher capacity based on genetics and all kinds of other things.
So another example of on the high end is I have a friend who's got a connective tissue disorder, and so they just have more compliance to the heart muscle, and so the way that they make that up is by a faster heart rate.
Interesting.
And so with heart rate, or with cardiac output, right? How fast are we delivering blood? It's a combination of stroke volume. So how many milliliters with each pump, and then heart rate, and that makes up our cardiac output. The reason I bring that up is I actually had a question yesterday about like, well, is this testing even useful if someone is on a beta blocker? Is it even useful to do max testing? And absolutely. Like, because there's two sides of that equation is like, yep, maybe their heart rate can only get so high, but as they make adaptations to the heart muscle itself, to the blood vessel system, to their oxygen transport and delivery systems, we can actually see that stroke volume go up. And so they're pumping more blood with each beat. And so they can actually get an improvement in their VO2 max because they're able to deliver more oxygen with each pump of the heart.
Well, and it's going to benefit all of their other body systems as well. And we can still want to know what heart rate ranges then they should be working out in and things.
Yeah.
Still very, very helpful.
And so again, like using multiple of these together, I'll just review them again. So plateau in VO2, RER of 1.1, we'll just make that easy. 9 to 10 out of 10 on your rating perceived exertion, and then like 95% of age predicted max. Those are all pretty good indicators to use. And looking at them in combination can help you identify like, okay, I'm confident in saying this is a max test.
Yeah. So we'll often use the term VO2 peak as well. VO2 peak is essentially the highest VO2 that you achieve during the test. And so if somebody stops early, it'll give their VO2 peak and then the extrapolated VO2 max.
Yeah.
And so,
and so just this, there are different ways that people define VO2 max versus VO2 peak.
Yeah.
And it's kind of this difference between like, this is research, and this is like practical use.
Application.
Practical application.
Yeah.
And so VO2 max is literally the highest max, like the maximum oxygen utilization, highest oxygen uptake you could have if like every condition was met, right? You're perfectly rested. It's in a temperature controlled room. You're strapped in. You can go to full exhaustion and you just give up into the harness. Right. Like that just is not not practical.
I tell people that all the time. I rarely have done a true VO2 max test. I usually do more of we find out what their VO2 peak is, and often that's very close to their VO2 max.
Yeah, and for practical purposes, like
and safety purposes,
like we call that a VO2 max. And two, like what we've talked about before is like VO2 max is not the only number we're concerned with. We're also looking at where are their thresholds? How do they utilize fats and carbohydrates to fuel their exercise, right? How are those energy systems working together? And so, as Cameron mentioned, using other things like the physiological side, how are our lungs integrating into this? What's neuromuscular efficiency like? Understanding some of those things that we can understand with this type of testing. Um, like, yeah, maybe could I have gotten, a few points higher on the VO2 max?
Right.
For sure. Is that going to practically change what I'm doing for training? Not really.
Well, what's clinically
And what's
significant?
clinically significant?
I think that's a
Absolutely.
huge point of like, if they have a 57 versus a 59 VO2 max, especially once you've kind of reached into that most superior category, from a health standpoint, that's clinically insignificant.
Yeah.
57 versus 59. From a performance standpoint, comparing people together, somebody with a 57 versus a 63, the 57 could actually beat the 63 in a race potentially.
Yeah.
Depending on all these other factors. So comparing VO2 maxes once you're kind of in that highest category actually doesn't speak that much towards intra or inter athlete performance. Whereas intra athlete with the same athlete, by going from a 57 to a 59, we will see performance improvements. And so that's where that kind of comes with a grain of salt, if you will, of what's clinically significant. And so probably not going to make a big difference, especially on a baseline test, whether they got 57 or 59. If we stopped a little bit early of maybe what they could have done, but we kept them safe, that's probably fine. Whereas, on retesting and other things like that, seeing those improvements can be important.
Yeah. One thing you do want to consider, though, is if I'm wanting to compare test to test,
Mm-hmm.
then I need to make sure that it's apples to apples.
Yeah.
And so that I'm using the same type of exercise testing equipment. I'm using the same protocol. I'm standardizing what I standardized before. Otherwise, it's like, oh, well, was just VO2 max higher because they did a treadmill test instead of a cycle test, the second time?
Right. Or the conditions were different, or their fueling was different, or so trying to control as many variables as you can, like
Absolutely.
we've talked about before.
Yeah. But I love that point that you brought up, is that like once we're at a sufficient point for VO2 max, then there are other things that become more important in terms of health and performance, right? So it's like I could have a really high VO2 max, but I could actually, like, I need more muscle mass, right?
More muscle mass or poor fat oxidation.
Poor fat oxidation.
So that I'm always in recovery when I'm training. So we do enough of the high intensity work, but we're not doing enough of the low intensity work to build a bigger base. And so more likelihood of injury, or, not as much base to sustain the lower intensity work on longer endurance type activities and stuff like that.
Yeah. I remember this. So can't remember the study I was looking at, but it was looking at, like, in terms of like cardiovascular ability, people that have been like Nordic skiers and they're comparing them to the regular, right? Like, awesome in terms of like cardiovascular fitness and like being able to like move around, but it didn't necessarily mean that they had more muscle mass than age matched norms. Like, I think they actually were very similar in terms of muscle mass to people of their like same age. And so it was like, even people that have like really good fitness into their older years, if we don't have sufficient muscle mass, like that still becomes a problem, right? We know that the fall, like risk of injuries from falls past the age of 65 goes up exponentially. And so there's multiple qualities to work on. To the performance standpoint, like when people are in that excellent, sort of that superior range of VO2 max, it's like, what's their lactate threshold? What's their running economy? Like, how fatigue resistant are they? Like, how long can they run at a given percentage of their VO2 max before, heart rate goes up, before substrate use changes, things like that.
Yeah, there's a lot of other ways that we can test people to determine relative fitness or relative performance instead.
Yeah. But again, like, this is why, like, where Cardio Coach comes in, like why we love using it for this type of testing is because we can run so many different types of testing. We can run different types of max tests. We can run different types of submax tests. And so it gives us a lot of latitude to test what we intend to measure.
Yep.
And so, like with the long form testing that it allows for, like that's where we can do, like, let's run you through a 60-minute workout and see how your fat and carb utilization changes, or how your oxygen consumption changes.
Right.
Let's do a fat max test to really dial in that zone 2 point. We're worried about some cardiac issues if we get too high, like we're going to run a submax
Submax
test.
test. Yeah.
Like it just allows us to easily create protocols and then identify the type of testing that's going to be most beneficial for that person and their goals, and also their safety and risk considerations.
Yeah. You know, with an athlete, you may start out with doing a VO2 max style test just to get that max value and to see where they're at from an overall fitness standpoint. But then the next couple of tests you run with them probably wouldn't necessarily be a max test again. You may be running more of, fat max tests, or looking at zone 2 or fatigue resistance tests, things that are looking at different aspects of their performance instead of just um, that VO2 max number. And so I think when, depending on who you're working with, what their goals are and what their limitations are, you can really change up what some of the submaximal tests are that you're doing to work on specific aspects of their training.
Yeah. One thing that I would add in is just doing a good pre-participation screening for your client, right?
Yep.
Ruling out any like musculoskeletal limitations, cardiovascular limitations, respiratory limitations,
Yep.
things like that that are going to impact results. Because having a complete picture of like what that person's been doing, what they're likely to be prepared for, will help you design the type of test that's going to be best for their given circumstances and is also going to be the safest.
Yeah. Yeah. So I really like the PAR-Q
Yeah.
participation questionnaire. It's called the PAR-Q. It's a well-validated measure. I believe ACSM recommends it, or it's one of them that's recommended. But it's just easy to use, and it's available for free to the public. And it's a great way of just making sure people are safe. It has a good kind of decision algorithm for screening people so that you can confidently say, oh yeah, we need to hold off on this test, or they need to go see their cardiologist, or I don't know, we'll be safe. You can follow up with a few things. If they mention orthopedic injuries, you can see what's the acuteness of that and severity of it, so that you can make sure that you design the test appropriately or postpone the test if need be. But usually we can, like I said, we can design the test then to say, maximal test is probably not what we want to do here. We're going to do a submaximal test that's symptom limited. So if they feel anything, we're going to stop. And you can safely test most people, just making sure you're taking into consideration the appropriate limitations based on what they answered on those tests.
Well, it also gives us good baseline information, even for very, very unfit people that we can't do a max for. Like just getting some idea of where they're at cardiovascularly can be so helpful,
Yeah.
and then can be a benchmark for, are the changes that we've made to their programming, their nutrition, et cetera, actually working.
That's something I've never tried before, but I just had that thought that would actually be a cool way of pointing out to a patient the progress that they've made, is have them refill out the PAR-Q like months down the road.
Yeah.
And show them how some of the things that were limitations before maybe are no longer limitations. That'd be kind of cool.
Yeah.
Anyway, there's a thought.
There's not. But bottom line, like, there's so many things that we can test, and for most people, we can do this type of testing safely, even if it's not a max test. And so again, test what you intend to measure and design the test that's going to give you the information that you want while keeping the patient safe. And so like, max tests are warranted for certain things, submax tests are warranted, or even the best choice for certain things that you want to look at.
Mm-hmm.
And depending on what you're selecting for, right? Like if it's research, if it's a stress test, there might be certain protocols that I go with. That's my purpose, is to get this, versus other types of what we'd still consider max testing. I want to get a better idea of their heart rate ranges, of their thresholds, things like that. And so there's tons of validated ways to use this equipment, this technology, and to use the data to help people lead healthier, more active lives.
Yeah. So put a plug in for asking questions again. If you do have questions about your situation or designing test protocols or things of that nature that you're still curious about, or that we maybe didn't answer, please drop that in the comments. Send us an email, whatever. Reach out. We would love to have those questions so that we can include those in future episodes, but also just so we can make sure that it's clear to you so that you can get the most out of your investment in the cardio coach.
Great. Well, as always, thanks for joining. And if you want more content like this, remember to like, follow, and subscribe, and we'll catch you next time. Ready to take your metabolic testing to the next level? Visit KORR.com to learn more about purchasing our metabolic test equipment.